Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey guys, welcome back to the Wild Health Podcast. Your host today, Dr. Jeff Graham. I am the Chief Medical Officer here at Wild Health, and super excited to have everybody back for another session. Today we're going to have one of our newest docs, Dr. Damon Forbes, joining us to talk about a new syndrome that we're starting to identify more in people, getting more and more coverage in the medical and specifically metabolic field. And that is one of lean mass hyper-responders. And for those of us who love to geek out on metabolic health, this research is super exciting because we feel like we're starting to understand why some people might suffer from metabolic disease despite not being overweight, not having the typical appearance that we think of, or the typical morphologic features that we see in folks with insulin resistance. So Dr. Forbes, welcome.
Thanks, man. I appreciate it. I'm excited to be here.
Yeah, for sure. And honestly, man, I got to give you some credit. You were the first person I think who brought this topic to my awareness. I had no idea this was out there. And the more rabbit holes I've gone down, and some of these experts I think we'll talk about today who are really leading the charge, it's super fascinating.
Yeah, I agree. I've had a long-term interest in low-carb diets, both on a personal level, just with experimentation in the past, and I've interacted with lots of patients over time that have followed that. So this was a topic that popped up on my radar, honestly, as a result of that, seeing folks who were following these low-carb ketogenic diets and then finding out that there's this, at least newly described phenotype that's probably been out there for a long time and just has gone unrecognized up to this point.
Yeah, yeah. Well, before we get into all the nuts and bolts around this, why don't you introduce yourself? Tell us a little bit about your background. One of our newest guys at Wild Health. We're super excited to have you on board, and we want people to get to know you a little bit.
Yeah, so I'm a pulmonary critical care physician by training. I think a lot of us went to medical school wanting to help people get well. At that time, I kind of fell in love with really complex disease and high acuity medicine, which is how I ended up ultimately in the ICU. I spent several years on active duty in the Army and did some general kind of pulmonary critical care medicine. And then my wife and family, we basically left active duty life and moved to Asheville, North Carolina, where I've been practicing really since that time, or 2020. And I think, honestly, it's in that 5 to 6 year time frame, I just had this recognition that so many of the illnesses that we see in the hospital setting are really rooted in long-term lifestyle issues. And by the time they get to the ICU, and in many instances, it's too late to certainly fix those issues. And certainly there's no opportunity to prevent them on the back end. And so that sort of sent me down a path where I was exploring holistic health and functional medicine training, eventually stumbled on precision medicine and wild health. And then I got an amazing opportunity earlier this year to basically jump on board and join the wild health team.
Well, we feel the same way, man. I know, shout out to Mike Stone for connecting the two of us after you did our fellowship. And it's just serendipitous. We happen to live in the same town.
Yeah,
So yeah, after a couple of coffee hookups,
that's right.
and I kept putting the pressure on you, and you're finally like, all right, man, all right, let's do this. So we're so excited to have you on board. But yeah, man, I have quickly realized that I think obviously you're a super bright guy, and your passion for, well, I mean, let's be honest. The first time that you showed up at a Wild Health meeting, you had on a T-shirt that said mitochondriac, which got me super excited. It's like, all right, this guy, is way into the metabolic pathways, and it sounds like you have a real passion for that. Is that correct?
I do. I think that's, metabolic dysfunction, mitochondrial dysfunction is present in so many conditions, and I think is one of the root causes of a lot of illness and dysfunction. And so, yeah, I've gone down lots of rabbit holes related to metabolic health and mitochondrial health optimization. And so I think that's certainly become a passion of mine.
Yeah, yeah. What do you do yourself? We'll dive into this, but I want to hear what you're doing to address your own mitochondrial and metabolic.
Yeah, great. So as I told you, I've done I consider myself a running N of one experiment, right? I've kind
Yeah,
of done every dietary intervention for 6 months to a year that you can think of over time, and really find that I do the best when I am more consistently low carb, not necessarily ketogenic, but maybe in that sort of 50 to 100 grams of carbohydrates a day. I've sort of liberalized that over this last 4 to 5 months, and sort of watched some metabolic parameters change. So I definitely, typically a whole food centric, mostly low carb diet. I definitely do a lot of sauna. I do strength training 3 to 4 times a week. Make sure to get a couple of zone two aerobic cardio sessions in, and then lots of cold plunging, which the data are a little bit mixed in terms of the long term outcomes, but I find personally that I feel fantastic when I do that more consistently. So I
yeah,
think those are probably that's the majority of the things that I do on a regular basis from a metabolic health optimization standpoint.
yeah. Great, man. Yeah, we'll definitely circle back around to some of those lifestyle changes, as they relate specifically to this particular phenomenon we're going to talk about today. But why don't we start out with just a 101? What is lean mass hyperresponder? What is this term actually referring to?
Yeah, that's a good place to start. And honestly, I think before we talk about the criteria, it's worth acknowledging the gentleman who really jump started this whole thing. And he's not even in healthcare. His name's Dave Feldman. He's a software engineer, and he put himself on a low carb diet in 2015, I think, to address some underlying metabolic issues. And what he noticed is that, being an engineer, I have no doubt that he was tracking lots of data points, but
Yeah,
he recognized that all of a sudden, even though his metabolic parameters at large got better on that he saw this massive spike in his LDL cholesterol numbers, and also saw a big rise in HDL, and then saw this drop in his triglycerides. And so, based on conventional wisdom, that LDL number was alarming, up front. And then he started to interact with other individuals online and in low carb communities, and recognized a pattern of this sort of collection of cholesterol findings, and then also in a population that tended to be lean, tended to be athletic. And so at some point after 2015, I think it was maybe 2017 or 2018, he formalized the criteria as he saw them, which is an LDL cholesterol level greater than 200, greater than or equal to 200, an HDL value, HDL cholesterol of 80 or more, and then a triglyceride value of 70 or less. Now, he acknowledged that those were just cutoffs, and I think you have to create some criteria at some point if you're gonna eventually follow this and study this. And so this is probably a spectrum, in term phenotypically speaking, and it may be that, we'll talk about some of the studies that have been done on the back end of this discussion, but, they've relaxed those criteria a little bit over time.
yeah, yeah. So thinking about, I mean, and I'm going to put you on the spot a little bit. I don't want you to feel like
Sure.
you're being pimped by, in your endocrinology rounds in medical school. But what's happening, or how can you best describe what's happening in this scenario where we've gone low carb?
Yep.
Ketogenic diets have been in and out of, popularity, but they really do work for some people because we see that at Wild Health. We, look at genetics and epigenetic markers, and they really are the best choice for a lot of people.
Yep.
But what's happening physiologically for these people who fit this criteria of lean mass hyperresponder?
Yeah, so what ended up happening after he created this definition or these criteria, they actually he couldn't get a lot of traction in conventional, academic medical circles or research circles. So he created a public charity called the Citizen Science Foundation to literally fund research into this topic by crowdsourcing. So the Citizen Science Foundation stood up. They started collecting crowdsourced funds to then start to study this phenomenon. And then what they noticed in cohort studies is that this seemed to be a legitimate phenotype and something that they were able to differentiate from familial hypercholesterolemia, or FH, for the sake of brevity. Um, it was really through those cohort studies and some trends they recognized that they needed to explain this physiologically, right? Because initially there was quite a bit of pushback that this was a real entity. People sort of thought this was maybe a one-off. And so he ended up partnering with several other authors, Nick Norwitz being one of them, Dr. Sotomoto, several others, and they proposed a physiologic model that they've termed the lipid energy model. And they
Right.
actually published this in Metabolites in 2022 for anyone's interested in looking at the actual article. And so the explanation, and we're going to simplify this greatly here, but when you are on a carbohydrate restricted diet for a prolonged period of time, your body will preferentially switch over to fatty acid metabolism as the preferred fuel source. And so as your glycogen levels are depleted in the liver starts to basically grab a bunch of these fatty acids and packaging them into triglycerides, which then get carried in something called VLDL. And so those VLDL particles move out to the circulation and through a bunch of other processes are going to basically be converted into LDL cholesterol molecules. And then there are a bunch of little remnants around the outside of the VLDL that then contribute to HDL cholesterol production. And so you're basically, your liver is pushing out a lot of additional fat, so increased sort of fat flux, as some people call it. And then it's the breakdown of those VLDL particles into LDLC, and then you get this HDLC upregulation. Your triglyceride levels naturally are going to be low because you're using those fatty acid sources as your primary fuel source at the tissue level, at the muscle level.
Okay. Yeah. Yeah. So that makes sense. And so one of the key things you just said is that when someone may switch from a, say a Mediterranean diet or whatever they're eating to more of a low carb or ketogenic diet, we don't see this right off. Is that
No,
correct? It takes some time.
it does. Yeah. I mean, I think glycogen depletion is necessary, and I think you need some consistency, right? So if you're doing low carb 4 or 5 days a week or 5, 6 days a week, and then you have a sort of a carb reload day, you're not likely to see this physiologic response. You don't have
Okay.
enough time to really, you're constantly sort of repleting glycogen levels. And so I think it would be difficult to see this pattern develop.
Yeah. Okay. Well, that's so interesting. So I think you've done a good job at explaining kind of what the proposed physiologic mechanism is. You mentioned Nick Horowitz, right?
Nick
That's
Norwitz, yeah,
Nick Norwitz. Yeah.
he is a fascinating, brilliant individual. He's an MD, PhD by training, recently just graduated from Harvard Medical School. He really has spent a bunch of time studying metabolic science. That's what his PhD background is in metabolism. And Nick, he's been involved with really from the very beginning at the development of this sort of concept, and then the subsequent studies that have been done. They actually did a couple of cohort studies before Nick did an N of 1 experiment that we'll talk about in a second. And what they saw was you could take this cohort of individuals with this phenotype and reintroduce carbohydrates. And those tiny cohort studies, they were using what we consider healthy carbohydrates, right? Sweet potatoes, bananas, things like that. And by reintroducing carbohydrates, you would see those cholesterol levels, particularly the LDL level, drop.
Yeah.
And that was predicted by the model, right? Because now you've got glycogen and glucose available as a fuel source, and your liver is not, dumping fatty acids basically through the LDL into the bloodstream. And so they didn't get a lot of traction with that study. It wasn't very interesting or exciting. And so Nick
I know where you're
designed,
going with this.
yeah,
This
what
is
I
so
think
good.
is a really a super insightful and intentionally provocative experiment on himself. So to provide more background, Nick has been on a ketogenic diet for several years now. He developed inflammatory bowel disease that was refractory to medical treatment. And Nick sort of went through a bunch of different dietary variations and found that the ketogenic diet put him into remission. And so he has been on a ketogenic diet faithfully for several years now, and that's what it uses to really control his inflammatory bowel disease. And so Nick at baseline is ketogenic. So he designed a very interesting study where he was going to compare statin therapy, which he does not take at baseline, to Oreo cookies, and to see which one of those ultimately had a larger effect on his cholesterol levels, specifically his LDL. And so he did this with the lipid energy model hypothesis sort of in mind. And so Nick did a 2-week sort of prep phase where he was very strictly on his ketogenic diet. And then he proceeded to eat 12 Oreos a day for 16 days. I think his baseline LDL cholesterol value was 384, so quite high.
Woo. Yeah.
And in that 16-day period, it dropped by 71% down to about 111. So an
By adding
unbelievable
Oreo cookies.
for 16 days. Yeah. And what was interesting is originally he was going to do 14 days, but when he did that lab draw, his primary care provider was like, "This doesn't make sense. We got to check it again." So on day 15, it was lower. Day 16, lower. So really, they stopped it at day 16, but there was a trend that his LDL cholesterol was continuing to fall even below the 111. So a massive reduction in LDL cholesterol, which we just don't see with medications. And so then he did a 3-month washout, back on the ketogenic diet, return his LDL to baseline. So I think before he started rosuvastatin, 20 milligrams a day, his LDL was back up over 400. And so then he did rosuvastatin for 6 weeks at 20 milligrams a day. And basically the end of that had about a 32% reduction in his LDL-C.
Okay. So he
So
was pulling more of that LDL out of the bloodstream with rosuvastatin, which we know that's how it works, but not nearly as profound as eating 12 Oreo cookies a day.
that's right. So Oreos were basically more than twice as effective as the statin drug. And he made this intentionally provocative, and it worked. I think he got over 400,000 YouTube views pretty quickly when this got released. But the point was that it wasn't even about the Oreos, right? I mean, Nick would never advocate eating Oreos on a daily basis for treatment of cholesterol. What he wanted to demonstrate is that really any carbohydrate source that gets reintroduced in this patient population will lead to a predictable drop in LDL cholesterol. And I think it was, although a one-person study, some validation of that proposed lipid energy model.
Yeah. Yeah. That's fascinating. So thinking about that, I mean, obviously Nick has some, and he's eating a ketogenic diet, but having an LDL that high is, pretty eye popping to
It
any
is.
physician. Yeah. So thinking about someone who we might find who's falling into this phenotype,
Mhm.
how dangerous is LDL? And we talk a lot at Wild Health about the greater number, the apolipoprotein B, which is that kind of aggregate number, lion's share made of LDL for sure. But how dangerous are those high numbers any more dangerous in this subpopulation?
I think that is one of the fundamental questions, and I
Yeah,
think the group of individuals that have been studying this, I think they have sought to explore that. I don't know that any of them would tell you that we have a confident answer, but we can talk about a couple of the studies that have been done to try to address the cardiovascular disease risk question that you just asked.
yeah,
Before we do that, one comment I would say is that the way I sort of think about it is that ApoB is a really good surrogate, or really is another way of thinking about the LDL particle number.
yeah.
The number of LDL particles in the bloodstream, and then LDL-C reflects sort of how much cholesterol gets packed into those LDL particles. So sometimes you will see different patterns where you'll see some discrepancy between your LDL cholesterol number and your ApoB.
And your
And
ApoB.
and that reflects just how much cholesterol is being carried by those particular particles.
For sure, and that's a really good point. That's an interesting distinction to make that I don't think is really clear to patients sometimes. So, yeah, I mean, that's where my mind goes with this is, if we're recognizing this as a new phenotype, and I think we're seeing probably is, and just the more and more literature comes out, we need to talk about some of that. But my question is again, like going back to, well, if this is the natural response for this phenotype and what we would consider an otherwise insulin sensitive, metabolically healthy individual, is it imploring more or conferring more risk? Is it conferring more metabolic and cardiovascular risk for that individual?
Yeah, I think that is a fundamental concern that a lot of us have with this, right? I mean, I think the data around ApoB is both a causative and a predictive number related to cardiovascular disease risk and progression. I mean, it's quite compelling, right? I mean, we've
Yeah.
got lots of data points and dealing randomization, meta-analyses, lots of data suggesting that ApoB has a causative role and as a very good predictor of cardiovascular disease risk. I think the individuals in this lean mass hyperresponder cohort would suggest that it may eventually turn out that ApoB is necessary, but not necessarily sufficient to drive the disease risk in certain elements of the population, right?
Yeah.
So what they did to at least start that process of answering that question, they organized a couple of studies. One of them was a cross-sectional study called the Keto Trial. It was published in 2024, and they looked at 80 individuals with the lean mass hyperresponder phenotype. They did relax the lipid cutoffs a little bit to try to make it slightly more generalizable. So they used an LDL-C value of 190, and then slightly lower HDL and slightly different triglycerides, but very close to the original lean mass hyperresponder definition. And then they did an age-matched cohort analysis comparison to 80 individuals from the Miami cohort studies. The Miami Heart Study basically follows a bunch of individuals that are not on a prescribed dietary pattern of eating. And what they looked at obviously cholesterol levels, and then they looked at calcium scoring CTs, and then they looked at cardiac CTA values. And what they ultimately found is certainly the lean mass hyperresponders had a much higher LDL level, and then they had an average calcium score of 0, and they had really no significant difference at all in the amount of plaque that was present on the CTAs between those two cohorts. And what was interesting is that the average duration of the dietary pattern was almost 5 years. So most of these folks who were on a lean mass hyperresponder phenotype, that cohort, had been on a ketogenic diet for an average of 5 years. And so that means they had presumably a lot of time being exposed to these markedly elevated LDL-C and by proxy potentially ApoB levels.
Yeah. Yeah. So that's impressive. Yeah, 5 years is plenty of time to start building disease, right? And you
It
said that,
certainly is. Yeah,
yeah,
especially now in the era of cardiac CTAs and some of
yeah,
the AI-read CTAs. I mean, the level of sensitivity and precision that we're getting with those, they're able to detect the tiniest amounts of plaque present, and they can actually see plaque progression even in a 12-month time span. So
yeah,
5 years with that amount of dietary exposure should have been sufficient to see some progression or some differences between those cohorts.
yeah. And were they tracking CCTAs over that time, looking
That
at?
was just that was basically an age-matched cross-sectional study. They wanted to compare that cohort to a cohort that was not on a ketogenic diet. It did not have the lean mass hyperresponder phenotype. Now, they subsequently took those 80 individuals, added 20 more, and did a longitudinal study that was published earlier this year.
Okay.
So
And
that
do
was
we?
called the Keto
Yeah.
CTA trial.
Okay. Yeah. Wow. Yeah, that's fascinating. And for me, where my brain goes, because, we do these at Wild Health, we have these add-on genetic reports, and that family history report that we'll get, that FH report, as you referred to earlier. One of the things that we probably ought to update that with these new trials, because it's really interesting. Frequently, I will have someone with a alarming cholesterol level. I think
Mhm.
of a guy who had a total cholesterol of 400, and his ApoB was up close to 200, and his LDL, was off the charts. It was like Nick's was.
Yep.
And he came back with almost a completely clean coronary angiogram looking at those coronary arteries.
Yep.
And it makes me think now, because this was a very healthy individual. He was weightlifting a lot, doing appropriate zone 2 training, taking care of himself, didn't have any signs of insulin resistance. So that's exactly who we're potentially talking about here, right?
Yeah, there are a couple of ways to think to differentiate between FH, which is a genetically determined,
Mhm.
lipid disease and carries a lot of cardiovascular disease risk with it, from the lean mass hyperresponder. And I think so. LDL levels are very similar in both groups. So LDL is not going to help you differentiate those things. ApoB probably doesn't either. Uh, Generally, you're going to have normal to even elevated triglyceride levels depending on which HF type you have. And you're not going to necessarily see the markedly elevated HDL cholesterol with the FH that you might see with lean mass
With
hyperresponders.
lean mass. Okay.
Yeah. And the other way to differentiate it is you don't have a big dietary response to FH, right? I mean,
Mm,
you generally just, when you're messing around with different dietary interventions, you don't see huge swings, and certainly in the LDL values. Whereas a lean mass hyperresponder, by definition, they have to be on a low carb, high fat, or ketogenic diet. They're generally going to be, as we've said, athletic and tend to be fairly lean. And by reintroducing even a little bit, a moderate amount of carbohydrates, 50 to 100 grams a day, you would expect to see a substantial drop in their LDL cholesterol level. You're not going to see that in FH.
yeah. Yeah, for sure. For sure. Yeah. Man. It's kinda blowing my mind, because I'm also bringing into thinking about what you were yeah, I think you posted this the other week in our physician channel about these what we're starting to see, maybe phenotypes for
Yep.
insulin resistance,
Mhm.
and where these 2 Venn diagrams might cross over, right? Um,
Absolutely. And I think we're in an era now where the ability to personalize healthcare is at an all-time high and is going to continue to grow. I mean, it's one of the most exciting times, I think, to be doing precision medicine or personalized medicine, because we're on the cusp of being able to, person to person, really dial into exactly what's going on physiologically, and then potentially to help personalize lifestyle interventions, treatments, and things along those lines. It's pretty cool.
Yeah, it really is. Yeah, so I think in my mind, the remaining clinical questions are exactly what we're talking about. Is there a reason to treat these people with more or less alarm when you see these LDL levels, given
Yep.
that everything else looks so normal? What about just the innate? We talk about cardiovascular disease as you already mentioned. We ApoB has a pretty compelling role that we see in
Yep.
those large trials. The other components I think of are inflammation for
Hmm.
sure, and then endothelial damage, right? So
Yep.
obviously, insulin resistance fits in that package,
Yep.
hypertension fits in that package. I'm just thinking about typically when I see someone who has off the charts cholesterol numbers, we know that a lot of these particles just by nature tend to be pro-inflammatory for the vessels. But I'm wondering in this scenario, if having an LDL that's this high in the setting of everything else being normal, do you think that inflammatory component exists?
I think it's less likely just because of again, this limited data. We don't have 20-year outcome data yet from this group. But when you look at the general sort of physical and metabolic characteristics, these folks tend to be exquisitely insulin sensitive. They tend to have low levels of inflammation. And so they generally don't have a lot of the other cardiovascular disease risk factors that you mentioned. I think it's important to explore those things for sure, because that is going to frame the conversation about how we react to this
Yeah.
cholesterol level, without a doubt. But I think at least based on the preliminary data, I referenced that follow-up longitudinal keto CDA trial. They basically didn't see, with subsequent CTA analyses 1 year apart, they did not see that there was any level of LDL cholesterol or ApoB that actually predicted the plaque progression that was present, right?
Yeah.
So they saw some plaque progression, and the factor that predicted that was the presence of plaque on the first scan. So if you've got cardiovascular disease, coronary artery disease, that alone is a risk factor for progression. And the rate of progression they saw was what we would typically see in secondary prevention trials, people on like statin
Yeah.
therapy and other lipid lowering therapies. That was about the amount of progression that we saw, the similar rate. Now, they involved Clearly, which we utilize, but they
Yeah.
have a bunch of other analyses are in the process of being completed. They're going to have data from HeartFlow, another AI CTA company, looking at the same scans. They're going to have Q angio data, and then they have a qualitative analysis done by expert physicians who have read those scans. So we're going to see several other publications that are going to come out, and I think there's a signal that we may actually see regression of disease in some of these individuals.
Yeah.
Whether that's statistical noise or whether that's a real finding remains to be seen. But I think using those scans to get back to your question can be very helpful in thinking about how meaningful is this markedly elevated cholesterol value, right? It may not be the same for this group as it is for other folks with other risk factors. But I think if you were to do a scan in a lean mass hyperresponder and you saw a fair amount of plaque, then that would be concerning, right? At that point, that there may be some future progression, but it's going to be based on that plaque alone and not necessarily the cholesterol values.
Yeah. So I'm wondering, just thinking about how much we're integrating AI with what we do at Wild Health already, and how much it's just inevitable that it's going to become a part of our management of patients in the future. Is there a world where we can build an algorithm that we're able to immediately, we get some metabolic numbers back, and we type it in here and it dings us and says, "Oh, this could be a lean mass hyperresponder," and would that affect management? Do you think that's coming? Is it already here?
I think there's real potential that it is going to happen, because I think AI gives us the ability to look for signals that we can't even detect really at the human eye level, and I think allow us to integrate some data that again right now is wholly unrecognized. So I'm optimistic that we are going to be able to utilize even some of our current diagnostic tools, but maybe embed machine learning or AI into those, and to be able to provide a much more rapid and precise estimate of somebody's true metabolic disease and risk. Yeah.
Okay. Well, I want to make sure that before we get done with this discussion, I'm going to make a shameless plea for who we should have next on this podcast. And it sounds like Nick is definitely someone who we'd love
Yeah, I
to.
would love to get Nick Norwitz and Dave Feldman on because I think there is a lot of nuance in certainly the more recent longitudinal keto CTA trial and results. It's been a lot of interesting pushback in the larger medical community about that and questions that I think are appropriate about generalizability. But I think the two of them are sort of must gets as far as guest. And then I think Professor Michael Snyder's a gentleman who's studying. He's
Yeah.
one of the most prolific metabolic researchers on the planet in relation to things like AI implementation. So those are three, I think, for sure.
Yeah. So, folks, I think one of the takeaways today, and I think Damon has said this so well already, is the advantage you get when you're, when you're working with someone like Wild Health is this precision medicine approach. Because, if you walk into any primary care doctor's office and you're everything looks great except your LDL levels off the charts and you're meeting criteria with the high HDL, you're not insulin resistant, we're not seeing these other signs of metabolic disease, you're gonna get a statin, right? I mean, that's just kinda we say if you're over this level, we figure out that 10-year ASCVD risk, and more than likely, you're gonna walk out with a prescription for a statin. In the end, the more that we uncover about this, that may not actually be what needs to happen. This is what I'm hearing, correct?
Yeah, I think that's a very fair summary. I mean, I think the authors of these studies would say we're not telling you that cholesterol doesn't matter. We're not
Yeah.
telling you that ApoB is not important and potentially problematic, but there may be more nuance than we realize, right? It may be that we find that ApoB is simply a surrogate for something that has not yet been recognized, right? There was a long time before ApoB was commonly utilized where we really thought about LDL cholesterol specifically. So I don't want anybody to walk away from this and think that you can generalize these cut points to a population at large, right? If you do
Yeah.
not meet these strict criteria, including carbohydrate restricted diet, that this probably doesn't apply to you, and that we're not saying that cholesterol is irrelevant, but I do think it requires a more personalized, nuanced approach than number equals treatment.
Oh, 100%. I mean, I would caveat to what I just said is that I spend more time every day talking people probably into statin therapy than
Sure.
out of it, because
Yeah.
there's, we have 50 plus years now of really good literature supporting cardioprotective effects of these classes of medicines that help to lower ApoB. And but yeah, I think what you said nails it. There seems to be more nuance to this topic than I think we've recognized, and I think it
Yeah.
deserves a deeper look than what you're usually getting in your, once yearly primary care visit. So
I think that's right, and there is an opportunity to utilize some of the diagnostics that we do at Wild Health, the AI augmented CTAs.
yeah,
For folks who are reluctant about lipid lowering therapy, and I think sometimes appropriately, or maybe they've had adverse reactions to some of those therapies, or there are cost concerns. Sometimes using like a clearly CTA or another AI CTA scan can be really useful to show us, okay, what's currently present and what is your risk of progression from there, right?
yeah,
That sometimes can help frame how important it is maybe to try therapy or to try a different pharmaceutical.
yeah, yeah, 100%, 100%. All right, man. So what studies on the horizon? Are we waiting on some other
Yes.
stuff that's yeah, tell me about what's going on in this field right now.
Yeah, so we have, as I mentioned, there are some additional analyses coming. The first analysis included some of the clearly CTA data, and as I mentioned, heart flow, Q angio, those data sets are coming. They use the same scans, right? So it was the same 100 scans, both at the baseline and the 1 year follow up. So we'll have additional papers that are going to really compare all of these different modalities, and there's some differences between how clearly looks at things versus heart flow versus Q angio. And then I anticipate we're going to have also longer, more longitudinal studies that are going to come from this. There are going to be potentially some carbohydrate reintroduction studies. There's some discussion about looking at how this affects athletes and how therapies might affect athletic performance. And so, yeah, I think there's a lot on the horizon. This is not going to go away. I think this is only going to become a richer field of study in the coming years.
Yeah. Yeah. So you have a connection to these guys, right? With Nick and Dean, we can be able to get them on.
I hope so. Yeah. So I'm going to ask Professor Snyder to help me out with that one. Yeah.
Good. Yeah. Yeah. He's in with these guys.
Yep.
We need to line up a whole just, metabolic block here to get
Yeah,
on.
there's an opportunity definitely to do almost like a low carb series here with
Yeah.
lots of different things around low carb diets for folks who are utilizing them. And I'm hoping that, yeah, as I said, hoping Professor Snyder can help get Nick and Dave on the
Would love to
podcast.
have that. Would love to have that, man. Yeah.
Yeah.
Well, guys, this has just been fascinating for me today. I hope you've been able to nerd out as much as I have here with Dr. Forbes. Damon, I really appreciate you coming on, man.
Yeah, absolutely. It's my pleasure. Super excited to be at Wild Health and looking forward to being on the podcast again down the road.
I think you're hosting one here soon, right?
I am, yeah. Late November, I'll be interviewing Dr. Snyder about diabetes subphenotypes and some of the AI technology that's on the horizon for personalized medicine.
Yeah. Yeah. Well, stay tuned for that one, folks. I think that's another super fascinating field and definitely has some overlap with what we talked about today. So lean mass hyper responders, you guys look it up. It's seems to be something that is really a hot topic right now. And we're super thrilled that Damon came and talked to us today some about it, put it on our radar. Hope you guys have enjoyed this episode of the Wild Health Podcast. Keep your eyes out for Dr. Forbes. He'll be working more and more with us. And we'll see you on the next episode. Peace.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.